Thank you again for joining us today. We're going to talk today about transvenous phrenic nerve stimulation for the treatment of central sleep apnea and Cheyne-Stokes respiration. My name is Robin Germany, and I'm the Chief Medical Officer at Respicardia, and I'm a clinical assistant professor at the Division of Cardiovascular Diseases at the University of Oklahoma. I've been with Respicardia now for 10 years, and I'm very excited to have Dr. Goldberg and Dr. Augostini speak with us today about this exciting new therapy for central sleep apnea. A few brief comments. The remedē system is an implantable phrenic nerve stimulator indicated for the treatment of moderate to severe central sleep apnea in adult patients. There are two contraindications: patients with an active infection and patients known to require MRI. As you can see here, there's a number of warning and precautions, and I would point you to our website for additional information and full description of all of these. Now, Respicardia was founded in 2006 with a mission to address the unmet needs in cardiovascular and respiratory diseases. The company is headquartered in Minnetonka, Minnesota, and it's dedicated to improving patient outcomes, quality of life, and overall cardiovascular health via novel transvenous neurostimulation therapies. The remedē system, which we're going to speak about today, is our flagship therapy, and I'm excited to share some of this information with you. The therapy has been in development for a number of years. So prior to FDA approval, we had been conducting research for over 10 years and over 275 patients across a number of studies, which are listed here. And the pivotal trial is the largest randomized trial in CSA to meet its endpoints and to show benefit to patients. But all of these studies have shown consistent improvements in sleep metrics and quality of life. We just don't have time this afternoon to go through each of these studies, so we'll focus today on the FDA PMA pivotal trial study. The remedē system was approved by the FDA in October of 2017, and commercial launch started in early 2018. Following launch, we've had a number of commercial milestones, including approval by CMS of both an inpatient and an outpatient additional payment, which supports novel therapeutic technologies. In addition, we have been approved by the VA Federal Supply Schedule, and we have a number of active VAs right now and plan to activate more by the end of the year. This has been supported by robust clinical evidence with the initial study findings published in The Lancet, followed by a number of articles in very prestigious journals as listed here. And just a couple of weeks ago, our 3-year data was published in the journal Sleep. Currently, the remedē is offered in 20 centers today with the intention of expanding to about 25 to 30 additional centers by the end of the year. So with that, I would like to introduce our two speakers, Professor Lee Goldberg from the University of Pennsylvania, who's the Section Chief in Advanced Heart Failure and Cardiac Transplantation. He's a professor of medicine at the Hospital of the University of Pennsylvania, and he is the Vice Chair of Medicine for Informatics. He's well NIH funded. He's had a number of chair positions at both the ACC and ISHLT, and is very well published in many journals that I'm sure you've seen in the past. He also has served on the steering committee for the pivotal trial and will be leading up our next clinical endeavor as well. Dr. Ralph Augostini is Associate Professor of Clinical Medicine at The Ohio State University. He's the Bob and Corrine Frick Chair in Cardiac Electrophysiology. He's also the co-director of the Electrophysiology Training Program and the director of the Ambulatory Device Clinic at Ohio State. In addition, he has worked with Respicardia for many years, helping to develop the technique of implantation and the tools that we're using in implantation today. I think this is going to be a very exciting program, and I urge you to stick around and ask questions following the program to hear more about central sleep apnea and this therapy. Thank you. And with that, I will turn it over to Dr. Goldberg.
Thank you very much, Robin. I'm going to cover several agenda items, including the background of central sleep apnea, the pivotal trial results from the remedē system, some data on the durability of response and subgroup analyses, and then I'll hand it over to Dr. Augostini to talk about the implant procedure. These are my conflicts of interest. Central sleep apnea is a debilitating disease that reduces quality of life and increases the risk of comorbidities, hospitalizations, and death. Central sleep apnea is a disorder in which there is a disruption in the neural drive to breathe during sleep. In this case, the brain does not stimulate the phrenic nerve in order to stimulate the diaphragm to create normal respiration. Patients with central sleep apnea are most likely to have heart failure and/or atrial fibrillation, although a small percentage of patients may have a brain injury like a stroke, and about 5 to 15% are idiopathic. 52% of the patients in our trial were 65 years or older. The typical patient with central sleep apnea is male, 55 years old or older, has a history of heart failure and/or atrial fibrillation, and complains of chronic fatigue, excessive daytime sleepiness, memory or concentration issues, mood changes, or headaches. Why is it important to treat central sleep apnea? Well, we know that for those patients that have heart failure, they are 50% more likely to have a heart failure-related readmission within 6 months and have twice the mortality rate than those patients who don't have central sleep apnea but also have heart failure. We also know that central sleep apnea increases the risk of other comorbid cardiovascular conditions like heart failure and atrial fibrillation. For our patients, this causes hypoxia and fatigue, but also poor quality of life. If we compare obstructive sleep apnea, which is the one that most clinicians are more familiar with central sleep apnea, we can see some key differences. Central sleep apnea is characterized by the fact that there is absolutely no effort, meaning that the diaphragms are not moving during the apneic phase, and therefore there's no flow of air at the level of the nose. This leads to oxygen desaturations and the other negative effects that we see in patients with central sleep apnea. On the other hand, in obstructive sleep apnea, the airway is closed, but there's tremendous effort by the diaphragms and movement of the abdomen, but no airflow during this time. So in obstructive sleep apnea, there's continued effort, but in central sleep apnea, the brain is not connecting well to the diaphragms, leading to loss of flow. Most patients with central sleep apnea have concomitant cardiovascular conditions, including heart failure and atrial fibrillation, as well as patients who've had strokes. About 75% of patients with central sleep apnea will have heart failure and/or atrial fibrillation. Central sleep apnea leads to intermittent hypoxia, arousals, and cardiovascular stress. And the mechanism of this is thought to be due to activation of the sympathetic nervous system. This activation leads to significant stress on the cardiovascular system, but also has a huge impact on our patients' quality of life. The poor sleep quality and hypoxia leads to fatigue, insomnia, daytime sleepiness, and poor concentration. And interestingly, some patients that report paroxysmal nocturnal dyspnea or nocturnal angina may actually be experiencing episodes of central sleep apnea with arousals. When we connect the central sleep apnea drive to the heart failure drive, we see that increased sympathetic drive puts a significant stress on the heart, leads to adverse myocardial remodeling, and therefore increases the risk of arrhythmias as well as worsening heart failure. We think that central sleep apnea drives heart failure, but also that heart failure likely is driving the central sleep apnea. We know that this is manifest in outcomes by looking at heart failure readmissions. For those that have central sleep apnea, if we look at their readmission rate within 6 months, those with central sleep apnea had a significantly higher risk of being readmitted to the hospital over the following 6 months from their index hospitalization. We also know that central sleep apnea has a huge impact on mortality. Its mortality is even higher than what we see in obstructive sleep apnea, and in both forms of sleep-disordered breathing, there's a significant mortality risk as compared to those that do not have sleep-disordered breathing. This makes it a very important therapeutic target for heart failure cardiologists who are concerned about improving survival as well as quality of life. Several other therapies have been evaluated for the treatment of central sleep apnea, and there have been several small controlled randomized trials to evaluate these. Theophylline has been studied in one small clinical trial with approximately 15 patients over just 5 days. This did show a significant decrease in the number of apnea-hypopnea events per hour, but there is concern about using theophylline in patients with heart failure as there is potential for increased risk for arrhythmias. Acetazolamide was also studied in one very small trial of 12 patients over 6 nights and demonstrated a reduction in apnea-hypopnea index and daytime fatigue, but interestingly, no changes in arousals. Acetazolamide can affect potassium metabolism and theoretically could also lead to cardiac arrhythmias in patients with heart failure. Oxygen has been studied in 3 small randomized trials, totaling approximately 49 patients, and showed an improvement in apnea-hypopnea index, but interestingly, again, no improvement in symptoms or arousals, and there are concerns that high oxygen levels may be harmful in heart failure patients. The CAMPAP trial was one of the first large randomized clinical trials to evaluate the use of CPAP in patients with central sleep apnea. The CAMPAP trial was halted early due to concern that there was minimal impact on the primary endpoint and also concern over higher mortality in patients with ejection fractions less than 40% receiving the CPAP therapy. Interestingly, in those patients that are prescribed CPAP, 25 to 50% of those patients refuse or are unable to tolerate the therapies, and only 40 to 60% are non-compliant, even to a minimal bar of about 4 hours per night, 5 nights per week. Finally, the adaptive servoventilation had also been touted as a potential therapy for central sleep apnea. This is a device that can apply positive pressure ventilations during the apneic phase of central sleep apnea. The SERVE-HF trial was a randomized trial that randomized patients to adaptive servoventilation. And it was noted that patients that were on the adaptive servoventilation had an increased risk of both all-cause and cardiac mortality for those patients that had symptomatic heart failure and left ventricular ejection fractions less than 45%. Based on this, the FDA issued a black box warning that said that adaptive servoventilation therapy was contraindicated in patients with chronic symptomatic heart failure with reduced left ventricular ejection fraction less than or equal to 45% and moderate to severe predominant central sleep apnea. So now let's talk about the remedē system pivotal trial clinical results. The remedē system is a phrenic nerve stimulator that's fully implantable and is designed to treat moderate to severe central sleep apnea in adults. It drives inspiration by activating the diaphragm by stimulating the phrenic nerve. It turns on automatically at night, ensuring therapy compliance, and is programmed much like a pacemaker. It's implanted by electrophysiologists. First, a pulse generator is implanted below the clavicle, and then both a stimulation lead and a sensing lead are placed during the implant procedure. This enables the device to sense respiration as well as patient movement and location, and combined makes the device fully automatic. The remedē system, based on the results of the pivotal trial, was approved in October of 2017 as the first of its kind proven alternative for central sleep apnea treatment. What's interesting is that the FDA noted in its release of the approval of the device that there are no currently effective alternative treatments available for the treatment of central sleep apnea. The system was approved as an implantable system developed to treat CSA by transvenously stimulating the phrenic nerve to restore a normal breathing pattern. So the design of the pivotal trial that enabled the FDA to approve the device was a prospective, multi-center, randomized controlled trial. The baseline criteria were moderate to severe central sleep apnea based on a polysomnogram with an AHI of greater than or equal to 20 events per hour. The central apnea index had to be at least 50% of all the apneas with at least 30 central apneic events. The obstructive apnea index had to be less than or equal to 20% of the total apnea-hypopnea index, which really helped us to ensure that the patients had predominantly central sleep apnea. The polysomnograms were scored by a blinded core laboratory. The patients were randomized to one of two groups. All patients received the device at baseline, and then therapy was initiated at 1 month. Half of the patients had the therapy turned on at the initiation visit, and the other half of the patients were randomized to therapy off. At 6 months, the primary effectiveness endpoint was measured between the therapy on and the therapy off groups. But then at that 6-month visit, all patients were then turned on, so the patients in the original control group crossed over to an active therapy group, and then the patients were followed out to 12 months to evaluate the primary safety endpoint. And then every 3 months thereafter, the patients were evaluated going forward. The baseline demographics for the patients in the pivotal trial included 65-year-old patients on average, About 86 to 92% of them were men. The body mass index was around 31, an ejection fraction of approximately 40%, remembering that not all patients in the pivotal trial were diagnosed with systolic heart failure. About 2/3 of the patients had heart failure on enrollment in the trial. About 40% or so had atrial fibrillation. About 40% had a concomitant cardiac device. And you can see that the patients met the inclusion criteria by apnea-hypopnea index and central apnea index. And in general, the patients reported being relatively sleepy by the Epworth Sleepiness Scale. If we look at the primary endpoint of the trial, which was a greater than 50% reduction in apnea-hypopnea index, there was a significant improvement in patients who were in the treatment arm as compared to the patients that were in the control arm. And this met the primary endpoint of the trial. The secondary endpoints were also all positive in the trial in a hierarchical fashion. If we focus, however, on some of the secondary endpoints that really looked at arousals, percent of time in REM sleep, and quality of life, this is the only treatment that has demonstrated in a randomized trial significant improvement in these factors. If we look at sleepiness and quality of life, we see an improvement in the Epworth Sleepiness Scale, which is the patients reporting how sleepy they felt. Patients' global assessment in general, marked or moderate improvement or mild improvement, was significantly better in those patients that were in the treatment arm. And the willingness to repeat the procedure, 95% of patients said that they were willing to go back through the implant procedure given the benefit that they received during the trial. In terms of the safety endpoint, 91% were free from serious adverse events associated with the implant procedure, the remedē system, or the delivered therapy at 12 months. There was a 97% implant success rate with a relatively low lead revision rate and about 2.7 hours to implant. And we know that over time, as our implanters get better, that those numbers will continue to improve. There were 6% implant-related serious adverse events and 1% therapy-related. Fortunately, there were no deaths related to the procedure, system, or therapy, and this is important given the data from the SERVE-HF trial. Well, what about the durability of response in subgroup analyses? We know that at 6 months, we had a positive impact, but what about further out? Well, we saw an improvement in apnea-hypopnea index was consistent with the vast majority of patients receiving a significant benefit. At 6 months, you can see that the vast majority of patients, 88%, demonstrated a decrease in the number of apnea and hypopneic events. And at 12 months, this was even slightly improved at about 91%. If we look out now for the long-term follow-up out to 36 months, we can see that the effect on apnea-hypopnea index, central apnea index, and oxygen desaturation index all persisted out to 36 months, and the arousal index also was improved out to 24 months. If we look just at the cohort of patients who had heart failure and looked at a post-hoc analysis at 12 months, we showed a significant improvement in all of the sleep metrics, as well as the Epworth Sleepiness Scale, and importantly, a heart failure-related quality of life instrument, the Minnesota Living with Heart Failure. The patient global assessment just in the heart failure population really mimicked what we saw in the trial as a whole, with a significant number of patients reporting that they felt improved as compared to the control group. Again, if we look at some post-hoc analysis of the heart failure cohort, we do see that there is an improvement in left ventricular ejection fraction, an improvement in time to first heart failure hospitalization, and a modest improvement perhaps in the Kaplan-Meier curve of months to cardiovascular death in patients with heart failure. Importantly, we didn't see an increase in heart failure mortality in this group, which had been seen in some of the other trials. All of these analyses are hypothesis generating, but we think we're moving in the right direction and certainly give us some hope that we may find a therapy that's impactful in patients with heart failure. Now I'm going to turn it over to Dr. Augostini to talk about the implant procedure for the remedē device.
Hello, here are my disclosures. I have received compensation from Respicardia for implant training. The Respicardia remedē system is an implanted neurostimulator for treatment of central sleep apnea. The system incorporates placement of a transvenous stimulation lead adjacent to either the left or right phrenic nerve. The goal is to create a strong, smooth inspiration which resembles a normal breath. Here there is a quadrupolar stimulation lead present in the left pericardiophrenic vein, which captures the adjacent left phrenic nerve. There is a delivery sheath which has been developed for deployment of the lead. It has a 7 French slitable body with stiffness transition zones and a soft flexible tip. It can hub to a safe sheath hemostatic valve if so desired. It is helpful to utilize an inner subselection catheter. I typically use either the CS vert or the CS hook for identifying and engaging the left target vein. An azygous right inner catheter is used to engage the azygous vein for separate sensing lead placement. The system is primarily placed from a right pectoral approach. There may be a coexisting left-sided device present in many of these patients. A crossing over technique from the superior vena cava with counterclockwise rotation of the delivery sheath and subsequent advancement of the 035J wire distally to the left subclavian or left internal jugular vein is easily performed. A CS vert subselection catheter is advanced over the wire removed, and the inner catheter slowly pulled back. Sometimes a drop in the catheter tip results in engagement of the target vein. Puff injections help to determine the location, which is often directly below the left internal jugular vein and over the aortic knob. Here we have actually engaged the left superior intercostal branch, which is not the target vein. Small puff injection slightly medial to the prior position demonstrates a beak with reflux of contrast down the suspected target vein, the left pericardiophrenec vein. Identification and access of this vein is the critical step of the implant procedure. The branch is then engaged with an 014 floppy wire. Typically, there is a valve near the ostium which can make access challenging. Advance the 014 wire distally to the left ventricular apex at the level of the diaphragm. If there is difficulty advancing the wire, a selective venogram can be performed. The venogram demonstrates parallel branches which are commonly observed in this particular implant. Attempt to engage the larger branch for lead delivery. Advise the patient to take several deep breaths to increase central venous return and engorge the target vein. This technique is quite helpful to achieve distal wire placement and subsequent lead delivery. The inner catheter is used to support advancement of the outer delivery sheath. Remove the inner catheter and advance the stimulation lead over the retained wire. Again, deep inspiration and typical CS lead delivery techniques help to advance the lead to its target location. On fluoroscopy, the lead is placed at the angulation between the left atrial appendage and the lateral left ventricular silhouette. We then test capture of the diaphragm. It is important to use only conscious sedation to assure the patient can report what they feel. There are some pain fibers which can be avoided by slight reposition of the lead location. Stimulation should result in a strong, smooth diaphragmatic capture. Typically, capture threshold is between 2 and 5 milliamps. A dedicated sensing lead is optional, but quite helpful for the future management of the device. The sensing lead is placed into an azygous vein branch using a coronary sinus delivery catheter and an azygous right inner catheter. The delivery sheath is advanced over a wire. The ostium of the azygous is identified at the level of the carina in an AP projection. A non-selective venogram will often demonstrate the ostium, which commonly has a valve. The azygous inner subselection catheter may be needed to advance a wire through the valve. A selective venogram in LAO projection demonstrates reflux across the valve into the body of the azygous vein. Gentle probing with an 035 glide wire can also be performed. Once the glide wire crosses the valve, it is advanced distally to the level of the diaphragm. Progressively advance the inner catheter and outer delivery sheath over the wire. As you can see, the azygous will straighten out considerably. An azygous venogram will demonstrate crossing vessels to the hemiazygous as well as target branching vessels laterally, typically at the level of the right atrium. The target branch is selectively engaged with an 014 floppy wire and the inner subselection catheter. It is helpful to advance the wire to the lateral thorax. The subselection catheter is advanced over the wire to lend support for subsequent advancement of the delivery sheath. A branch vessel venogram confirms the vessel size will accommodate a sensing lead. The outer delivery sheath is advanced and the inner subselection catheter is removed while retaining the 014 floppy wire. The sensing lead is advanced over the wire. An off-the-shelf bipolar coronary sinus lead is deployed. Once the leads are in their designated deployment sites, the outer delivery sheaths are slit, the leads are secured at their tie downs, and the device attached using typical techniques for a cardiac implantable electronic device. Learning curve and implant time are similar to CRT device implants. I will now hand off to Robin to close out.
Thank you very much, Dr. Augostini, and thank you, Dr. Goldberg. It's been great to hear from you both today. I'd like to talk just a few moments about how to offer the remedy to your patients. You can refer your patients to an active remedy center. Obviously, both UPenn and as well as Ohio State are centers for implantation. But there are additional active centers that may be closer to you that you can find at our website, or you can email us at info@respicardia.com, or you can also offer the remedy at your own center. So if you're interested in becoming a remedy center, please email us right here at info@respicardia.com. And then with that, I'm going to kick off the questions and discussions. All three of us will be here to answer any additional questions you might have. Please type them in.